Hello, wonderful people. It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my anatomy playlist, where we review each anatomy subject in just 3 videos. In the last 3 videos, we talked about the anatomy of the abdomen and the clinically oriented anatomy of the abdomen. Today, we shall start our pelvis discussion. Not just pelvis, but pelvis and perineum. You see this area up here? This is called the false pelvis. But down here, you have the true pelvis. This is the pelvic inlet. The border here is called the pelvic brim. And this is the hip bone with its famous acetabulum, which is gonna articulate with the head of the femur bone. This is the hip bone, but this will be the hip joint. You have 2 hip bones, but you have 1 sacrum in the middle. And please don't forget that the inguinal ligament extends from the anterior superior iliac spine to the pubic tubercle. Click the like button, click the subscribe button, and let's get started. Please watch the videos in this anatomy playlist in order, especially the last one titled Anatomy of the Abdomen. In this playlist, there is anatomy for the upper extremities, lower extremities, abdomen, pelvis, perineum, head and neck, thorax, and more. Each region in human anatomy is discussed on 3 separate videos. The first video is called Quick Review, the second video is titled Ultimate Review, and the third video is named Clinically Oriented Anatomy of that region. So here you have 8 regions multiplied by 3, 24 videos, and you will know more anatomy than most people. Today we have a quick review of the pelvis and perineum anatomy. In the next video we'll have ultimate review, and after that clinically oriented anatomy of the pelvis and perineum. As you know, clinically oriented anatomy is my favorite subject. What are we going to talk about? We'll talk about the pelvis and perineum. We'll talk about pelvic bones, joints, ligaments, and muscles of the pelvis. Then we'll talk about the viscera, the rectum, the anal canal, the urinary bladder, and the urethra, and the difference between the male urethra and the female urethra. Don't forget that the male urethra is longer than the female urethra, and that's why urinary tract infections are less common in males than females. We'll talk about the male baggage, including prostate gland, the scrotum, the testicles, the epididymis, the vas deferens, the seminal vesicles, and the male copulatory organ. Then we'll talk about the female organs, the ovaries, the fallopian tubes, also known as the oviducts or uterine tubes, the uterus, the cervix, the vagina, and the vulva. Then we'll talk about the peritoneal folds, the peritoneal ligaments, the uterovesical pouch, and the uterorectal pouch, also known as the pouch of Douglas or the cul-de-sac of the pelvis. We'll also talk about the broad ligament of the uterus, the round ligament of the uterus, the ovarian ligaments, and much more. Then we'll talk about arterial supply, venous drainage of the pelvis, then lymphatic drainage, as well as innervation of the pelvis. After that, it's clinically oriented anatomy. First, the basics, the non-negotiables, the very fundamental fact, the extremely fundamental facts that you cannot afford to make mistakes on. Look at this. This is a posterior view of the left buttock. This is the hip bone, this is the femur bone, this is the hip joint. This foramen right here is the greater sciatic foramen. Greater sciatic. Oh, what do you think the name of the nerve that passes through it will be called? Oh, sciatic nerve. Precisely. Please note the surface anatomy for this sciatic nerve. Super important. And that's why if you're giving an intramuscular injection in this area, stay away from the sciatic nerve. Stay superior and lateral to make sure that you're far away from the sciatic nerve. Because if I ask you, my dear student, can you give this injection to the patient? Please do not say, oh, of course, doctor, that's a piece of cake, I'm gonna do it. And then before you know it, you injure the patient's sciatic nerve. There is nothing more pseudo than the confidence of a young buck. You will make a mistake, of course, and injure the patient's sciatic nerve, and then the patient will complain of what? Well, I cannot extend the hip. I feel tingling and numbness at the posterior aspect of the thigh. You know what happened, right? you screwed up. So please study carefully because your patient's health depends on it. Here at Medicosis, we love Socrates, but we have no tolerance for mediocrities. Another key non-negotiable is the distinction among the foregut, the midgut, and the hindgut. Abdominal, esophagus, stomach, and the upper half of the duodenum is foregut. Then, the lower half of the duodenum, jejunum, ileum, ileocecal valve, cecum, appendix, ascending colon, hepatic flexure, and most of the transverse colon are midgut. Then, the distal 1/3 of the transverse colon, the splenic flexure, the descending colon, the sigmoid colon. Why do we call it sigmoid? Because it looks like a Greek sigma. It is bendy and twisty, as you see. After the sigmoid colon, there is the rectum and there is the anal canal. And just like there is medical education before medicosis and medical education after medicosis, there is the anal canal before the pectinate line and anal canal after the pectinate line, proximal to the pectinate line and distal to the linea pectinatum. Another non-negotiable. Where do coronary arteries come from? If you do not say ascending aorta in 3 seconds, I'm not going to talk to you anymore. After the ascending aorta, we have the aortic arch. The aortic arch has 3 branches, also non-negotiable. Brachiocephalic artery, left common carotid artery, left subclavian artery. Then descending thoracic aorta, pierce the diaphragm at the level of T12, enter into the abdomen, and change your name into the abdominal aorta. Here is the abdominal aorta like this. It is gonna supply the diaphragm via inferior phrenic arteries. It's gonna supply the foregut by celiac trunk. It's gonna supply the midgut by superior mesenteric artery. It's gonna supply the hindgut by inferior mesenteric artery. It's gonna supply both of your kidneys, renal arteries. Since you have 2 kidneys, the renal arteries are at the level of L2 vertebra. The abdominal aorta also supplies the adrenal gland, also known as suprarenal glands. The abdominal aorta is gonna give lumbar branches for the lumbar vertebra, is gonna give us 1 median sacral artery right smack in the midline, and it's gonna end at the lower level of L4 or upper part of L5 vertebra by bifurcating into right common iliac artery and left common iliac artery. Each common iliac will divide into external iliac artery, which will continue as the femoral artery in the thigh, as well as the internal iliac artery. The external iliac is basically the blood supply for the lower extremities, whereas the internal iliac is the arterial supply of the pelvis, which is today's topic. The main artery of the pelvis is the internal iliac artery, and the main vein of the pelvis is the internal iliac vein. The main lymph nodes of the pelvis are the iliac group of lymph nodes. And let me tell you something, I forgot to add one of the branches of the abdominal aorta. This branch is gonna leave the side of the abdominal aorta just like this, and you have 2 of them, one on the right, one on the left. This is called the right gonadal artery, and this is the left gonadal artery. In females, it's called the right ovarian and left ovarian, but in males, it's called the right testicular or left testicular. So the testicles and the ovaries are embryologically part of the abdomen, not the pelvis, a fact that is of utmost importance for oncologists and pathologists because they gotta follow the metastasis pattern of testicular cancer and ovarian cancer. These cancers will metastasize to the aortic groups of lymph nodes. Let me tell you something. You see this? This is the inguinal ligament, which extends between the anterior superior iliac spine and the pubic tubercle. The external iliac passed deep to the inguinal ligament to become the femoral artery in the thigh. But before the external iliac passed deep to the inguinal ligament, it gave us 2 famous arteries, one laterally and one medially. The lateral one is the deep circumflex iliac artery. The medial one is the inferior epigastric artery, which will supply the lower part of your anterior abdominal wall. It will keep going up, up, up. It climbs up until it anastomoses with the superior epigastric artery. Where did the superior epigastric artery come from? It came from the internal thoracic artery, also known as internal mammary artery. And these 2 arteries love to synapsarize right around your umbilicus. This is the abdominal aorta, right common iliac and left common iliac. Then we have external iliac on the right side. It will pass deep to the inguinal ligament to become the femoral artery. If you want to learn more about the femoral artery, watch my video titled Anatomy of the Lower Extremities. This is the symphysis pubis. This is the hip bone. This is the acetabulum, which will articulate with the femur, forming the hip joint. This is the obturator canal, which is an opening in the obturator membrane, which is a membrane in the obturator foramen. How about this canal? Oh, this is the inguinal canal, just inferior to the inguinal ligament. As you see, the inguinal ligament extends from the anterior superior iliac spine to the pubic tubercle. All of this is the hip bone, and it's made of 3 pieces. This is the ilium with an I, not with an E. Ilium with an E is part of your midgut. It's the one that comes after the jejunum. We say jejunum and then ilium. However, ilium with an I is part of the hip bone. So that's the ilium. Then what? This is the ischium, and this is the famous ischial tuberosity which you sit on. If you have examined the unfortunate patients who have marasmus or cachexia or anorexia, you would have noticed that the ischial tuberosity is very prominent. So this is ilium, this is ischium. What is this? This is pubis. Now this is a ramus, meaning an arm, and this is another arm, ramus and ramus. This is called the superior pubic ramus, and this is called the inferior pubic ramus, also known as ischiopubic ramus. Between the ischiopubic ramus on this side and the ischiopubic ramus on the other side, there is a famous triangle, known as the urogenital triangle. Uro for urine, genital for genitalia. Quiz time. What is the type of joint that is present in the symphysis pubis? Please comment below. If you wish to see more anatomy videos in the future, please drop a bone emoji in the comments. You see this? Oh, deep to the inguinal ligament, there is the famous vein. This is femoral vein, femoral artery, femoral nerve, psoas major, and iliacus, as they join tendons together. These 2 muscles will insert into the lesser trochanter of the femur bone. Please remember that vein goes from medial to lateral, like this, not like this. I mean, do you want the vein to hit your pubis? No! So you want the vein to move away from you. V is medial, then A, then N is the lateral. What is this? Oh, this is the abdominal aorta. It's going to branch into right common iliac, left common iliac. Each common iliac will give us internal iliac artery, the main artery of the pelvis, and external iliac artery, which will become femoral, and that's the main artery of the thigh. What is that artery right here in the midline? That's the median sacral artery. Another non-negotiable is the anatomy of the anal canal. There is the anal canal proximal to the pectinate line, and there is the anal canal distal to the pectinate line. The proximal part belongs to the hind gut. It's part of the gut. But the distal part is part of the outside skin. And that's why the proximal part is derived from the endoderm, but the distal part is an ectodermal derivative. When it comes to blood supply, we also have a clear distinction because the proximal part is supplied by the artery of the hindgut, which is the inferior mesenteric artery. As for the distal part, it's not supplied by the artery for the hindgut. There is also a difference in their venous drainage. And there is difference in the innervation. Up here, visceral autonomic innervation. Down here, somatic innervation. The proximal part, insensitive to pain, but sensitive to distension. Distal part, sensitive to pain. And that's why if you have watched my surgery videos, I've taught you the difference between internal hemorrhoids and external hemorrhoids. Internal hemorrhoids bleed, but external hemorrhoids hurt, because these are somatic fibers that are sensitive to pain. Does that mean that the internal hemorrhoids can never hurt and the external ones can never bleed? I did not say that. I'm just saying that the internal hemorrhoids are more likely to bleed, whereas the external hemorrhoids are painful. This is the abdominal cavity. This is the pelvis, pseudo-pelvis up here, true pelvis down here, and then down there will be the perineum. All of this is called the anterior abdominal wall. Here is a lateral view. This is the skin of the anterior abdominal wall, followed by the superficial fascia. Then you have the abdominal muscles. The abdominal muscles are three: external abdominal oblique, then deep to that, internal abdominal oblique, then deep to that is the transversus abdominis muscle, and this is the fascia of the transversus abdominis muscle known as the fascia transversalis. Then there is extraperitoneal fatty tissue, followed by the parietal peritoneum, and then the abdominal cavity will be here. Be careful with these three abdominal muscles, because the external abdominal oblique muscle will give us the external spermatic fascia. The internal abdominal oblique will give us the cremasteric muscle and fascia. As for the transversus abdominis with its fascia transversalis will give us the internal spermatic fascia. To learn more about the spermatic cord, please watch the previous video on the abdomen. By the way, if you want to watch more review videos like this one, check out my playlist titled Medicosis Quick Review and another playlist titled Medicosis in 90 Minutes, where you will find anatomy of the abdomen in 90 minutes, anatomy of the pelvis in 90 minutes, cardiology in 90 minutes, gastroenterology in 90 minutes, endocrinology in 90 minutes, pathology in 90 minutes, and more. What's that? That's the inguinal ligament from the anterior superior iliac spine to the symphysis pubis, and these are the layers of the abdominal wall. You have skin, followed by superficial fascia, then you have the muscles. Abdominal muscles include external abdominal oblique, then internal abdominal oblique, then transversus abdominis muscle with its fascia. Its fascia has an opening known as the deep inguinal ring, also known as the internal inguinal ring. And then the spermatic cord is going to pass through it and then through the superficial inguinal ring, which is an opening in the aponeurosis of the external abdominal oblique. So this is the superficial inguinal ring, and this is the deep inguinal ring. Who passes through both of them? In males, it's called the spermatic cord. In females, it's called the round ligament of the uterus. And don't forget the famous vein. This is femoral vein, femoral artery, femoral nerve, and then psoas major and iliacus joining tendons until they insert into the lesser trochanter of the femur. What is this lovely oblique muscle? Oh, that's sartorius. To learn more about the muscles and vessels of lower extremities, please watch my anatomy video titled Anatomy of the Lower Limb, which you can find in this anatomy playlist. What is this vein? Oh, this is the great saphenous vein, which drains into the femoral vein. This is the superficial inguinal ring, also known as the external inguinal ring, also known as the subcutaneous inguinal ring. And you see that's the spermatic cord emerging out. The spermatic cord is the lifeline of the testis. There is a spermatic cord on the right and another one on the left. The two testes live inside the scrotum. The scrotum is just one sac. So normally the male subject has one scrotum. What are the layers of the scrotum? The outside layer is the skin, followed by dartus muscle. It's the dartus muscle that's gonna send an inward septum to divide the scrotum into two different compartments, one for the right testicle, one for the left testicle. After the dartus muscle, we have a membranous layer of superficial fascia, then external spermatic fascia, deep to that, cremasteric muscle and fascia, deep to that, internal spermatic fascia, and then there is the parietal peritoneum of the scrotum, known as the tunica vaginalis. Tunica means coat because it covers the testis. Vaginalis means invaginated. This is the spermatic cord. Here is the superficial or external inguinal ring. And here is the deep or internal inguinal ring. The external inguinal ring is a gap in the aponeurosis of the external abdominal oblique, whereas the internal inguinal ring is an opening in the fascia transversalis, which belongs to the transversus abdominis muscle. External abdominal oblique removed, followed by internal abdominal oblique pulled to one side, followed by the transversus abdominis muscle, and look at this opening. The opening belongs to the transversus abdominis. It's an opening in the fascia transversalis. Here is the inguinal canal. Starting at the deep inguinal ring, until you find the superficial inguinal ring. This is the internal inguinal ring, and this is the external inguinal ring. Who passes through them? The spermatic cord. What are the coverings? On the outside, there is the external aponeurosis of external abdominal oblique, followed by internal abdominal oblique, followed by the fascia transversalis, and this deep inguinal ring belongs to the fascia transversalis. What are the contents of the inguinal canal? Spermatic cord and ilioinguinal nerve. The ilioinguinal nerve is part of the canal, but it's not part of the spermatic cord. As for the spermatic cord itself, it includes the following: 3 structures, 3 arteries, 2 nerves, and 1 remnant. 3 structures: the vas deferens, the pampiniform plexus of veins, lymphatics, and then 3 arteries: testicular artery, cremasteric artery, and artery of the vas deferens. 2 nerves: cremasteric nerve and testicular sympathetic plexus, and 1 remnant, which is the vestige of the processus vaginalis. In embryology, this is the processus vaginalis. The proximal part will fibrose and obliterate. As for the distal part, it becomes the tunica vaginalis, which is an extension of the peritoneum. So it also has a parietal layer and a visceral layer. Here is the spermatic cord on the right, spermatic cord on the left. This is the superficial inguinal ring, which is an opening in the aponeurosis of the external oblique muscle. The spermatic cord is the lifeline of the testis. It has testicular artery, testicular vein, and vas deferens, among other structures that we have just talked about in the last slide. Look at this, that's the vas deferens taking sperm from the testis up and up and up until you reach the urethra. It also has spermatic artery, spermatic vein. It has the artery of the vas deferens, as well as cremasteric artery for the cremasteric muscle. Look at this. This is the tunica vaginalis. On top of the testis, there is the epididymis, which is the beginning of the vas deferens. So you go testis, then epididymis, then vas deferens. At the midline, the scrotum has a median raphe. This is the back of the abdomen, this is the back of the pelvis, and this will be the perineum. The word perineum means perianal, around the anus. With all of the non-negotiables out of the way, let's start our lecture by talking about the bones of the pelvis. And after we finish the pelvis, we'll talk about the perineum. Bony pelvis. So, the bony pelvis consists of 2 hip bones articulating with 1 sacrum in the midline. The hip bone is made of 3 pieces. This is the ilium, this is the ischium, and this is the pubis. The pubis on the right and the pubis on the left unite together at the symphysis pubis. Symphysis means connection at the pubis. It's also known as the pubic symphysis or symphysis pubis. Between the sacrum and the ilium, there is the sacroiliac joint, which is notoriously destroyed in a disease known as ankylosing spondylitis, which I have discussed in my rheumatology playlist. This anterior concavity of the ilium is called the iliac fossa. Between the iliac fossa on the right and on the left, we have the false or pseudo pelvis. But down here, we have the true pelvis. This is the pelvic inlet, which is the inlet of the true pelvis, and this is the border of the true pelvis, also known as the pelvic brim. False pelvis versus true pelvis are also known as greater pelvis versus lesser pelvis. What are the boundaries of the true pelvis? Here on the back, we have the promontory of the sacrum, then the arcuate line of the ilium, followed by the pectineal line of the pubis. So the arcuate line belongs to the ilium, but the pectinate line belongs to the pubis. Can you name a muscle attached to the pectineal line? Please comment below. After the pectineal line of the pubis, here we have the pubic crest. And above it, we have the pubic tubercle. And don't forget that the inguinal ligament is between the anterior superior iliac spine and the pubic tubercle. From here to here is the antero-posterior diameter, but this is the transverse diameter of the true pelvis. You can also measure an oblique diameter. And these have medico-legal significance in forensic pathology, because if you have a subject that succumbed to his or her death in an explosion. You, as a forensic pathologist, can tell whether the subject was a male or a female based on the dimensions of the pelvis, among other differences. You see this bone right here? That's the pubis, and this ramus is the superior pubic ramus. As for that one, that's the inferior pubic ramus. It's also known as the ischiopubic ramus because it's between the ischium and the pubis. These two right here are called ischial spines. Up here, we have the iliac crest. These two wings of the sacrum are called the ala of the sacrum, and these are the sacral foramina. After the sacrum, you have the coccyx. The coccyx is going to give us attachment to the coccygeus muscle. The coccygeus muscle is one of the two muscles that form the pelvic diaphragm. Coccygeus is number 1, and levator ani muscle is number 2. What was the name of the lovely artery that passes in the midline down the sacrum right here? Oh, this is the median sacral artery, a branch of the abdominal aorta. All of this was just a quick review, but now let's talk about each bone separately in greater detail. This is the hip bone, ilium, ischium, and pubis. This is the iliac crest. It has an inner lip, outer lip, and intermediate zone. Anteriorly, we have anterior superior iliac spine. How about this? Anterior inferior iliac spine. Posteriorly, there is posterior superior iliac spine, and below it there is posterior inferior iliac spine. This is the iliac fossa, also known as the wing of the ilium. This is the arcuate line of the ilium, which forms part of the border or the pelvic brim. Between the ilium and the pubis, there is an iliopubic eminence. This opening right here is the obturator foramen, mostly obliterated by an obturator membrane, leaving a tiny canal open, and that will be called the obturator canal. As for the pubis, it has the symphysis pubis, pubic crest, pubic tubercle. This is the superior pubic ramus, and this is called the pecten or the pectineal line of the pubis. As for that ramus, that's the inferior pubic ramus or ischiopubic ramus, and this is the ischial spine. All of this was the pelvis as seen from above. But look at this. This is the pelvis as seen from below. This is anterior, this is posterior. Here's the symphysis pubis, and here's the sacrum. Between the sacrum and the ilium, you have the sacroiliac joints. What type of joint is the sacroiliac joint? Please comment below. What is this thing right here? Oh, that's the acetabulum, which will articulate with the head of the femur bone. Superior pubic rami, ischiopubic rami. In the living body, this acetabulum has an outer rim that has an acetabular labrum, which is going to be a component of the hip joint. The articular surface of the acetabulum is called the lacunar surface. Sacrum is here and coccyx is here. This is the hip bone. Up here we have the ilium, then we have the ischium, then we have the pubis. How about here? This is the ilium, this is the ischium, and this is the pubis. And this is the symphysial surface of the pubis, and this will articulate with this, and they will form the symphysis pubis. Honestly, this will never articulate with this because this is a right hip bone and that is a right hip bone, so they will never articulate. But the right will articulate with the left. This is the sciatic notch. And there are some ligaments that we will discuss shortly that will create a greater sciatic foramen and a lesser sciatic foramen. The sciatic nerve passes through the greater sciatic foramen. Here we have anterior superior iliac spine, then anterior inferior iliac spine, posterior superior iliac spine, and posterior inferior iliac spine. And this is the greater sciatic notch, which will be converted to the greater sciatic foramen. And this is the lesser sciatic notch, which will become the lesser sciatic foramen thanks to the ligaments. You see this iliac fossa, it will be floored, absolutely floored by a fleshy muscle known as the iliacus muscle. The iliacus lies in the iliac fossa. And that's the anterior aspect of the ilium. How about the posterior aspect of the ilium? Don't forget your glutes. Gluteus maximus, then gluteus medius, then gluteus minimus. This is the obturator foramen, which will be floored and obliterated by an obturator membrane, leaving only a tiny canal known as the obturator canal. What are the names of these two doozy ligaments? One is going to be called sacrospinous ligament, and the other will be called sacrotuberous ligament. The one that attached to the ischial spine is the sacrospinous. The one that attached to the ischial tuberosity, the thing that you sit on, is the sacrotuberous ligament. This is the anterior aspect of the sacrum, but this is the posterior aspect of the sacrum. The sacrum is formed of 5 sacral vertebrae. Here is S1, S2, S3, S4, and S5. The sacrum has a base, it has an apex, it has an anterior pelvic surface, and a posterior dorsal surface. The base of the sacrum is formed by S1 vertebra. It is known as the promontory of the sacrum, but the 2 wings are called the ala of the sacrum. Then the apex of the sacrum is down here, and it's going to articulate with the coccyx. There are 5 bony vertebrae, but 4 pairs of sacral foramina. On the anterior aspect, we call them anterior sacral foramina, and on the posterior aspect, we call them posterior sacral foramina. The nerves of the sacral plexus will emerge through the sacral foramina. The anterior aspect of the sacrum is related to the following: 3 muscles, 3 ligaments, 3 nerves, 3 vessels, and 3 viscera. The 3 muscles are the iliacus muscle, the piriformis muscle, and the coccygeus muscle. The coccygeus muscle is part of the pelvic diaphragm. The 3 ligaments are the anterior longitudinal ligament, of course, because these are vertebrae, the lumbosacral ligament, and anterior sacroiliac ligament. The 3 nerves are, we have sympathetic chains, one on the right, one on the left. We have the lumbosacral trunk and the anterior primary rami of the sacral nerves, and that's the sacral plexus. To learn more about the lumbar plexus and the sacral plexus, watch my video on the lower limbs. The 3 vessels, median sacral vessels, lateral sacral vessels, and superior rectal vessels, because the rectum will be here. The 3 viscera include the sigmoid mesocolon, the sigmoid colon, and the rectum. We're done with the anterior surface of the sacrum. Let's talk about the posterior sacrum. It has median sacral crest, 4 pairs of dorsal sacral foramina, and at the lower end we have the sacral hiatus. There are 3 muscles attached to the posterior aspect of the sacrum, and these include the multifidus muscle, the sacrospinalis muscle, and the gluteus maximus muscle. You see this? This is the sacral canal, deep inside the sacrum. What are the contents of the sacral canal is a very important question. And these include, the spinal cord. Shut the French toast up. The spinal cord ends at the level of L1 or L2. Lumbar, not sacral. There is no spinal cord once we hit the sacrum. Instead, we have the ponytails of the spinal cord, the cauda equina. Cauda equina literally means tail of a horse. What does bovine mean? Related to cows. What does canine mean? Related to dogs. What does swine mean? Related to pigs. What does equine mean? Related to horses. You did not expect to learn about this in a medical lecture, did you? Did you? So again, the structures of the sacral canal include the cauda equina, because the spinal cord has already ended between L1 and L2. The dura and the arachnoid motors that used to surround the spinal cord will continue down here. The filum terminale, which connects the lower part of the spinal cord to the coccyx. Then we have arteries and veins. The arteries are called the lateral sacral arteries, and the veins are called the internal vertebral venous plexus. And some loose areolar connective tissue, because why the hell not? For the last time, the contents of the sacral canal include the cauda equina, the dura and arachnoid mater, the filum terminale, the lateral sacral artery, the internal vertebral venous plexus, and some connective tissue. This is the sacrum as seen from above. It's made of sacral vertebra, and that's the body of the S1. The wings are the ala. This is the same wing as seen from the lateral aspect. This is the articular surface that will articulate with the ilium of the hip bone. Hashtag sacroiliac joint. As for this lower part, it will give attachment to the two famous ligaments, sacrotuberous ligament and sacrospinous ligament. The one that's going to attach to the ischial tuberosity is the sacrotuberous ligament. The one that will attach to the ischial spine is the sacrospinous ligament. Next, the difference between the male pelvis and the female pelvis. Some of you think that these differences are a social construct. This idea in your head right now is like the square root of a negative number, imaginary. The differences between the male pelvis and the female pelvis are concrete, and they are not just few differences, there are more than 20 differences between the male pelvis and the female pelvis. How do you think forensic pathologists were able to tell the difference between the male pelvis and the female pelvis before DNA tests? Using the following differences that I'm going to describe. If a male subject and a female subject fell off a mountain, and then after their bodies fell to the ground, an explosion took place, destroying everything. The only thing that's left is the bony pelvis from the male subject and the female subject. Can a good forensic pathologist tell the difference between the male and the female without DNA test? The answer is yes. Are the tools available to the forensic pathologist back in the day as accurate as a DNA test? Of course not. But we work with what we have. So what are the differences between the male pelvis and the female pelvis? Number one, the weight. The weight of the male pelvis is heavier than the weight of the female pelvis. Next, the male pelvis is stronger. It's more difficult to crush these bones. Next, the bony markings, as you can see here, are more prominent than the bony markings in the female pelvis. Next, the joint surfaces, the articulation surfaces, are larger in the male pelvis compared to the female pelvis. Next, if we add L5 right here, the fifth lumbar vertebra here and here, we will find that the articulation surface between L5 and S1 represents about half of this entire surface right here, but in females it's about 1/3. In other words, this area in the female is wider than that in the male, and that was a difference in the lumbosacral joint. Next difference is in the sacroiliac joint. The sacroiliac articulation surface in the male took 2.5 pieces of the sacrum, but in females it only took 2 segments of the sacrum. Next difference is in the acetabulum. The acetabulum in the male pelvis is larger than the acetabulum in the female pelvis. And if you measure the width of the acetabulum from here to here and from here to here, in males that width is the same as the distance from this margin to the symphysis pubis. Of course, because this is just an anterior view, you cannot appreciate this, but if you rotate the pelvis and look at the acetabulum and actually take a measurement, this width is about the same as this measurement right here, this length, but in females, this width is less than this line. In other words, the female pelvis is wider. The following difference is the fact that the symphysis pubis in males is longer than the symphysis pubis in females. The next difference is in the false or pseudo-pelvis or greater pelvis. The greater pelvis in males is very deep, as you see here, but in females it's relatively shallow. The next difference is harder to appreciate from a picture, but it's evident when you actually examine the bones in your hands. The anterior superior iliac spine in males is more inverted. It's tilted more to the inside, but in females it's tilted more to the outside, everted. Next, the pelvic inlet in males looks like a heart if you look at it from above, but in females the pelvic inlet is oval or rounded like a circle, not shaped like a heart. Why is this? Because the male sacral promontory is more forward projecting. but in females it does not project forwards as much. In other words, the female pelvis is wider to make it easier for the passage of the baby through the birth canal during labor and delivery. Next, the pelvic cavity itself. In males, it is deeper, but in females, it's shallower, but wider. Next, how about the pelvic outlet? The pelvic outlet in males is narrower, but in females is wider. For many reasons, including the fact that this angle is more acute in males, but more obtuse and wide in females. And notice that the ischio-pubic ramus is not the same. Don't forget that the greater sciatic notches in males are narrower, but in females they are wider. Next, all of the pelvic diameters are wider in females than males, whether you're measuring the anteroposterior diameter, the transverse diameter, or the oblique diameter. The ischial spines in males are more inverted, but they are less inverted in females in order to make the cavity wider. The coccyx in males projects forwards, but in females it projects downwards to make the cavity wider. The male sacrum is longer, but the female sacrum is relatively short. The male sacrum is narrower, but the female sacrum is wider. The pelvic surface, or the anterior surface of the sacrum, is more curved in males and less curved in females. When you compare the body of S1 to the entire base of the sacrum, in males it's about 1/3, but in females it's about 1/4, this diameter to this diameter as a ratio. This one divided by this one. And I've told you before that this articulation surface at the sacroiliac joint took 2.5 segments from the sacrum in males, but only 2 segments in the sacrum of females. Why is that important? Because this makes the female sacrum more mobile. It is movable. It can tilt a little to allow the baby to pass through during delivery. That's enough of the differences for novices, but for professionals, there are more differences between males and females in the pelvis.
Hey, medicosis, besides the pelvis, are there any other bony differences between males and females in other parts of the body?
The answer is yes. Next, the types of the pelvis in general and the female pelvis in particular. The classical female type is called gynecoid pelvis. The classic male pelvis is called android pelvis. If the pelvis looks like our evolutionary ancestors, it's called anthropoid pelvis. And if the pelvis is relatively flat, it's called platyploid pelvis. And that's why it really breaks my heart when I hear a proud feminist feeling so happy and positive that her phone operates on an Android operating system. Quote, I'm a proud feminist and I have an Android phone. Do you even understand what the word Android mean? This generation is doomed. If you are really true to your values, your phone should utilize a gynecoid operating system. It's called Gynecoid 14.0. This is the femur. Here's the head of the femur, neck of the femur, and then the shaft of the femur.
Epiphysis, metaphysis, diaphysis.
The head of the femur will articulate with the acetabulum of the hip bone. This is the greater trochanter, this is the lesser trochanter, and this is the intertrochanteric crest between them. Don't forget that the iliopsoas tendon inserted onto the lesser trochanter of the femur. You thought that ligamentum teres is only part of the liver. No, there is another ligamentum teres in the femur. So you can argue that we have a ligamentum teres hepatis, not to be confused with the ligamentum teres femoralis. We talked about bones, let's talk about ligaments. Here is the greater sciatic notch and lesser sciatic notch. Then we will draw 2 ligaments. Between the sacrum and the ischial spine is sacrospinous ligament. Between the sacrum and the ischial tuberosity is the sacrotuberous ligament. And these 2 ligaments will change the notches into foramina. So this becomes the greater sciatic foramen, and this becomes the lesser sciatic foramen. Look at this. This is the sacrotuberous ligament, and this is the sacrospinous ligament. This became the greater sciatic foramen, and this is now the lesser sciatic foramen. Here is the sacrotuberous ligament, and here's the sacrospinous ligament. This is the greater sciatic foramen, and this is the lesser sciatic foramen. This is the obturator foramen, which will be covered and obliterated by an obturator membrane, leaving a tiny obturator canal. This is the sacroiliac ligament. You have one anterior and one posterior, and they strengthen the sacroiliac joint. This is the anterior longitudinal ligament. On the back, we have supraspinal ligament. Between the ilium and the lumbar vertebra, we have iliolumbar ligament. This is from behind and this from front. And of course, between the anterior superior iliac spine and the pubic tubercle, you have the inguinal ligament. Deep to it, we have femoral vein, femoral artery, femoral nerve, and then the iliopsoas tendon. Don't forget that the sciatic nerve passes through the greater, not the lesser, but the greater sciatic foramen. Do not injure this nerve while injecting. Otherwise, I will smack your gluteus maximus, metaphorically speaking. Next, let's talk about the joints. This is the sacroiliac joint. This is the symphysis pubis. Between the acetabulum and the femur, we'll have the hip joint. Between lumbar vertebrae and sacral vertebrae, L5 and S1, we have the lumbosacral joint. Let's talk about muscles. This is the psoas major muscle. This is the iliacus muscle, which floors the iliac fossa, as you see. Then, the psoas major and the iliacus will join forces together in one tendon known as the iliopsoas tendon until they insert into the lesser trochanter of the femur. And these two muscles passed deep to the inguinal ligament. Psoas major muscle is supplied by L1, 2, and 3 from the lumbar plexus. As for the iliacus muscle, it's supplied by the femoral nerve, which is the nerve that's gonna supply the anterior aspect of your thigh.
Who's gonna supply the back of my thigh?
Oh, that's gonna be sciatic.
Who's gonna supply the medial aspect of my thigh?
That will be obturator. This is the psoas major muscle. We call it psoas major because there is another one called psoas minor. And this is the iliacus muscle, and they will join forces together. This is my beloved sartorius. This is the quadriceps femoris muscle, which is made of 4 pieces. Here is rectus femoris piece. This is vastus medialis, and this is vastus lateralis. So these are 3 pieces of the quadriceps muscle. What is the 4th member of the quadriceps muscle? Please comment below. Then we have pectineus muscle attached to the pectineal line, adductor longus, which will adduct your hip, and the most medial, the most graceful, gracilis muscle. Your quadriceps femoris muscle will make a tendon known as the quadriceps tendon, which will swallow the patella and then insert into the tibia down there. This quadriceps tendon is hammered in a disease known as Osgood-Schlatter disease. Psoas major and iliacus. You see this? This is psoas major, and this is iliacus. And don't forget that the ureter of the kidney starts anterior to the psoas major and then becomes medial to the psoas major. The ureter passes behind the testicular or ovarian vessels, and that's why we say water under the bridge, which is what Adele referred to in her famous song Water Under the Bridge. She was talking about the fact that the ureter passes behind, under the ovarian vessels. But of course, her fans did not understand the reference because they have the collective IQ of a patient with congenital hypothyroidism. I'm joking, of course. Psoas major versus iliacus muscle. Psoas major, origin from the transverse processes of all 5 lumbar vertebrae, L1 through L5. What's the insertion? Oh, they join forces. The iliopsoas tendon is gonna insert into the lesser trochanter of the femur. Nerve supply of psoas major, lumbar plexus directly from L1, 2, and 3, anterior primary rami, of course. The action of the psoas major, acting from above, it can flex your thigh, i.e. flex your hip, i.e. bring your thigh closer to your abdomen. And it's not just pure flexion, it is flexion with some internal rotation. Acting from below, it can bend your trunk forwards towards your thigh. If only one psoas major acted alone, it can bend your trunk sideways. That's lateral flexion of the spine. Iliacus muscle. Origin. I'm called iliacus because my origin is from the iliac fossa and iliac crest and iliolumbar ligament between the ilium of the hip bone and the lumbar vertebra. Insertion is the same as the psoas major into the lesser trochanter of the femur after passing deep to the inguinal ligament. Nerve supply of iliacus is from the femoral nerve, and action of the iliacus is to flex the thigh. If you want to learn about the gluteus maximus, gluteus medius, gluteus minimus, and even tensor fascia lata, please watch my video on anatomy of the lower extremities. The iliopsoas tendon passes deep to the inguinal ligament. The obturator foramen is obliterated for the most part by the obturator membrane, leaving only a tiny obturator canal here. This obturator membrane will give rise to an obturator externus, externally, and deep within obturator internus, internally. This is your hip from behind. This is superior gemellus and inferior gemellus, two little gems. This is piriformis muscle, which looks like a pear. It inserts to the greater trochanter of the femur, but the iliopsoas inserted into the lesser trochanter of the femur. This right here is obturator internus, but on the outside we have another obturator externus. Both the obturator internus and externus are gonna insert on the femur near the greater trochanter. This is the big overarching gluteus maximus. Remove it. Gluteus medius. Remove it. Gluteus minimus. This is piriformis muscle reaching for the greater trochanter of the femur. This is obturator internus. Obturator internus is carrying gemellus superior above it and gemellus inferior below it. And just like we had quadratus lumborum in the abdomen, we have quadratus femoris in the lower extremities. If the main muscle in the anterior thigh is the quadratus femoris muscle, then the main muscles in the back of your thigh are the hamstring muscles. This is the obturator foramen obliterated by the obturator membrane. And because we're looking from the outside, this is obturator externus. And what is the only gap left in the obturator membrane? The obturator canal. What passes in the obturator canal? Obturator nerve and obturator vessels. This is piriformis muscle that's gonna reach for the greater trochanter of the femur. Then we have the pelvic diaphragm, made by the coccygeus muscle posteriorly and levator ani muscle anteriorly. We call it coccygeus because it's attached to the coccyx. We call it levator ani because it literally elevates your anal canal and rectum to prevent it from prolapsing. If I have a weakened pelvic diaphragm, I can suffer from rectal prolapse, which means my rectum has left the chat, it has left my body and is prolapsing downwards. Or I can get vesical prolapse, which means the urinary bladder, in front of the rectum of course, prolapse downwards. In females, there is also uterine prolapse. In my humble opinion, the coccygeus and the levator ani muscle are so underrated. There needs to be an international day for the coccygeus and levator ani, and we will call it the Pelvic Diaphragm Day, to celebrate the fact that these two muscles protect my pelvic viscera from prolapsing. Why are my viscera not falling onto the floor? Thanks to my pelvic floor. Now let's look at an anterior view. Look at this beauty. This is your hip bone. This is the ischial tuberosity, the thing that you sit on. Between that bony prominence and the chair that you're sitting on is a pad of fat hidden in the ischiorectal fossa. You have a pad on the right, a pad on the left. And that's why you're sitting nice and comfy. Do you think medicosis will be able to record more than 2,300 videos if it weren't for a very robust ischiorectal fossa? I would not. The border of the true pelvis is the pelvic brim. And this is the cavity of the true pelvis. Here is obturator internus covering the obturator foramen and obturator internus covering this obturator membrane. And the obturator internus is covered by what? By obturator fascia. From the obturator membrane and obturator internus and obturator fascia, you'll find that the levator ani took its origin from here, and then the fibers will fan inwards towards the midline. and they will insert together here. The levator ani is a very broad muscle. Its superior surface is supplied by S4, but its inferior surface is innervated by the pudendal nerve. Speaking of the pudendal nerve, it is a loyal member of this pudendal canal. The pudendal canal contains pudendal artery, pudendal vein, and pudendal nerve. Is the pudendal nerve somatic or autonomic? Answer, somatic. Voluntary or involuntary? Well, if it's somatic, then by definition it's voluntary. And that's why it will supply the voluntary sphincter, i.e. the external anal sphincter, because the external anal sphincter is voluntary, but the internal is involuntary. Oh, that's going to be supplied by autonomic fibers, not somatic fibers. What is the origin of the levator ani muscle? It's a very broad origin, including the pelvic surface of the body of the pubis as a bone, the tendinous arch of the obturator fascia, which covers the obturator internus muscle, here and here, and also from the inner surface of the ischial spine. All of these are the origins of the levator ani muscle. And then these fibers will pass downwards and medially until they meet at the midline. The anterior-most fibers will surround the vagina in females or the prostate in males. Then we have intermediate fibers surrounding the rectum and anal canal. Then we have posterior fibers near the coccyx. We're done with the pelvis. Let's talk about the perineum. What does perineum mean? It means perianal. This is the perineum because it's around the anus. And of course, we'll have skin followed by superficial fascia. And what surrounds the anus is the external anal sphincter. The external anal sphincter is voluntary and supplied by somatic nerve fibers, which are branches of the pudendal nerve. Around it, we have the levator ani muscle, whose fibers are continuous with the fibers of the external anal sphincter. And this is the gluteus maximus muscle. I want you to get your pen and draw this diamond right here. Okay, what is here anterior is the symphysis pubis. Posterior, there is the coccyx. On the left side and the right side, we have the two ischial tuberosities. Now let's apply this here. The symphysis pubis is about here. The coccyx is here. And then right and left ischial tuberosities as you see. What if I added another point right smack in the center? That will be called the perineal body. Behind the perineal body, we will find the anal canal. What is the pelvic diaphragm? The pelvic diaphragm is made of the levator ani muscle anteriorly and the coccygeus muscle posteriorly. The levator ani muscle is made of three parts. The most anterior fibers in females form a sphincter around the vagina called sphincter vaginae, and in males they elevate the prostate a little, levator prostatae, but these fibers are very thin. The main fibers are these and these. The more anterior ones are the puborectalis part of the levator ani muscle. The more posterior part are the iliococcygeus fibers of the levator ani muscle. It's easy to remember that puborectalis is more anterior if you remember that the pubis is more anterior, but the coccyx is more posterior. And look at this, the iliococcygeus muscles are very close to the posterior coccygeus muscle. If you really want to understand the perineum, get a pen and doodle with medicosis. Okay, I want you to draw that beautiful diamond. Okay, that's amazing. And then a transverse line like this. What is anterior? Symphysis pubis. What is posterior? The coccyx. What is on both sides? The ischial tuberosity. What's right smack in the middle? The perineal body. Behind the perineal body is the anus. All of this is called the perineum because it's perianal. Now this transverse line has divided my rhombus into an anterior triangle and a posterior triangle. The anterior triangle is called the urogenital triangle because it has some urinary parts and some genitalia. As for the posterior triangle, it's called the anal triangle because it contains the anal canal. What is this? This is the pubic arch, i.e. the ischiopubic ramus. Oh, that V shape? Yeah, it's the inverted V shape that you have below your symphysis pubis. Symphysis pubis here, and then this is the ischiopubic ramus and ischiopubic ramus. So we call this the pubic arch. So if these two diagonal lines are the ischiopubic rami, then what are these two diagonal lines? Oh, these are the sacrotuberous ligaments from the sacrum to the ischial tuberosities. What are these transverse muscles that start at the perineal body and end at the ischial tuberosity? We'll call them transverse perineal muscles. And you have superficial transverse perineal and deep transverse perineal muscle. This will have your pelvic diaphragm. The most posterior muscle is the coccygeus muscle. And then more anteriorly, there is the levator ani muscle. Around the rectum and anus, there is the puborectalis part of the levator ani muscle. And then around it we have the iliococcygeus muscle. What I have just described is called the pelvic diaphragm. But do not confuse the pelvic diaphragm with the perineal membrane, because the perineal membrane is only gonna cover the anterior triangle, which is the urogenital triangle. Let's do it again. Here is my rhombus. The anterior triangle is the urogenital triangle. The posterior triangle is the anal triangle. The anus is more posterior, but the vagina and urethra are more anterior. This is the symphysis pubis, this is the coccyx, and these two are the ischial tuberosities. These are two ischiopubic rami forming the pubic arch, and these are the two sacrotuberous ligaments from the sacrum to the ischial tuberosities. The perineal body is right here in the center, and these are the transverse perineal muscles. There you go, urogenital triangle here, anal triangle there. This is the symphysis pubis, this is the sacrum or coccyx, ischial tuberosity. This is the pubic arch made by the two ischiopubic rami on the right and on the left. But behind we have the two sacrotuberous ligaments from the sacrum to the ischial tuberosity. The perineal body is right smack in the middle. You have transverse perineal muscles. We have superficial ones and deep ones. Behind the perineal body is the anus. In front of the perineal body, we have the perineal membrane flooring this urogenital triangle. Look at this. You can appreciate this rhombus shape. This is my diamond. Okay, what is the most posterior? That's the coccyx. Most anterior? That's the symphysis pubis. Right smack in the middle is the perineal body. Behind it is the anus. What are these two transverse muscles? These are the transverse perineal muscles. Attach me to the ischial tuberosities. Covering my sacrotuberous ligaments are the two glutei maximii. The levator ani is surrounding the anus as you see. The fibers that surround the anus are called puborectalis, and the outermost fibers are the iliococcygeus muscles. And then these two muscles are the bulbospongiosus and the ischiocavernosus. The bulbospongiosus are the ones that provide the pulsatile forces of ejaculation. The mnemonic that I use to memorize this, and I apologize in advance, is bulbospongiosus muscle is gonna help me bust seminal fluid. Here is a similar diagram in females. Please appreciate the rhombus. Anterior, symphysis pubis. Posterior, sacrum or coccyx. On both sides, the ischial tuberosities, the thing that you sit on. What's that in the middle? Perineal body. What are these transverse muscles? Transverse perineal muscles. What are these anterior muscles? The inner one is bulbospongiosus muscle, the BS, followed by ischiocavernosus muscle. The levator ani muscle is here. It is surrounding the external anal sphincter. The part of the levator ani muscle around the anus is called the puborectalis, but the outermost part is going to be called the iliococcygeus. Both are parts of the levator ani muscle. And of course, the gluteus maximus is going to cover everything. From posterior to anterior, we have anal canal, vaginal canal, urethral meatus, clitoris. By now, your triangle has become even more robust. Let me draw both triangles like this. Okay, that is amazing. This is the urogenital triangle, and this is the anal triangle. Anterior, symphysis pubis. Posterior, sacrum or coccyx. On both sides, ischial tuberosities. Right smack in the middle, perineal bodies. These are the two ischiopubic rami, so this forms the pubic arch, and these two are the sacrotuberous ligaments. From the perineal body to the two ischial tuberosities, we have transverse perineal muscles. The anal canal is here, vagina and urethra are here, urogenital versus anal. The fact of the matter is that I have transverse fibers like this, transverse perineal muscles. I also want to go anterior like this, and I also want to go posterior like that. If you want to go anterior, you got to be careful, because if you're medial, that is BS. Bulbospongiosus muscle. If you want lateral, ischiocavernosus muscles. How about behind? That's levator ani followed by coccygeus muscle. The levator ani is made of two parts. The innermost part, puborectalis. The outer fibers, iliococcygeus. Next, some splanknology actions. Let's talk about viscera. Splanchnic means visceral, means autonomic, means involuntary, means insensitive to pain but sensitive to distension. We'll talk about the rectum, the anal canal, the bladder, and the urethra. Starting with the gut. Remember that the anal canal above the pectinate line is part of your gut, but below the pectinate line is part of your outer skin. This is the lovely colon, also known as large intestine, starting with the cecum, which has the vermiform appendix, and then ascending colon, hepatic flexure, transverse colon, descending colon, sigmoid colon, rectum, anal canal, above the pectinate line and below the pectinate line. What's the difference between anal canal and anus? Anal canal is the entire canal. It's about 4 centimeters long, but anus is just the orifice. It's just the opening. If you did not know about this distinction, there is no hope for you. Abdominal, esophagus, and stomach for gut. Upper half of the duodenum, still for gut. Lower half of the duodenum, jejunum, ileum, ileocecal valve, cecum, appendix, ascending colon, hepatic flexure, and the proximal 2/3 of the transverse colon, mid-gut. The distal 1/3 of the transverse colon, the splenic flexure, the descending colon, the sigmoid colon, the rectum, and the anal canal above the pectinate line is hindgut. How about the anal canal below the pectinate line? Oh, that's just part of the external skin. Above the pectinate line, autonomic, i.e. visceral. Below the pectinate line, somatic. Above the pectinate line, insensitive to pain, but below the pectinate line, sensitive to pain. Internal anal sphincter, involuntary, but the external anal sphincter is voluntary. Autonomic versus somatic. Involuntary versus voluntary. What's the artery of the foregut? The celiac trunk. What's the artery of the midgut? Superior mesenteric artery. And what's the artery for the hindgut? Inferior mesenteric artery. Which means the inferior mesenteric artery is responsible for the arterial supply of the distal third of the transverse colon, the splenic flexure, the descending colon, the sigmoid colon, the rectum, and the anal canal above the pectinate line is still part of the IMA. However, the anal canal below the pectinate line, that's a different arterial supply. Above the pectinate line has its own venous drainage, but below the pectinate line has a separate venous drainage. Above the pectinate line, insensitive to pain. Below the pectinate line, sensitive to pain. Above the pectinate line, autonomic innervation. Below the pectinate line, somatic innervation. Above the pectinate line is gonna drain to the same group of lymph nodes as the hindgut. Below the pectinate line is gonna drain to the same group of lymph nodes as if we are in the skin, i.e. superficial inguinal lymph nodes. These are not part of the gut. This is the descending colon, then the sigmoid colon, formerly known as the pelvic colon. After the sigmoid colon, there is the rectum. What does the word rectum mean? Rectum from rectus means straight. Does anyone remember the rectus abdominis muscle? Rectum means straight. It goes straight downwards to the anal canal. Can you appreciate the hip bones? Can you appreciate this iliopsoas, which are joining forces to make one tendon that's going to insert into the lesser trochanter of the femur? Can you appreciate vein from medial to lateral, femoral vein, femoral artery, femoral nerve? We need an international day to celebrate the levator ani muscle. Does the peritoneum reach all the way down here? Yes, indeed. The peritoneum reaches almost everywhere. And the sigmoid colon will attach to the sigmoid mesocolon, which is a peritoneal fold. This is a posterior view. This is the external anal sphincter. Above the anal canal, there is the rectum. And the peritoneum reaches here, so these are peritoneal recesses. The ischiorectal fossa is filled with fat. The ischial tuberosities are what you sit on. Note that the ischiorectal fossa is below the levator ani. This ischiorectal fossa can develop ischiorectal abscess. Abscess is a collection of pus. Abscess is acute inflammation. What are the cardinal signs of acute inflammation? Redness, hotness, swelling, pain, loss of function. The fluid in the abscess, is it an exudate or a transudate? It's an exudate. Why? Because it's protein rich. What kind of proteins? Bacteria, bacterial debris, inflammatory cells, inflammatory mediators, cytokines, toxins, all kinds of gunk. Any abscess around this area is called perianal abscess. An abscess can rupture and create a lumen, create a connection with the anal canal, and this is going to be called an anal fistula. It can also create a fistula with the outside skin. And the patient will describe the symptoms as, I always soil the underwear. What is soiling the underwear? Stool. Where is the stool coming from? It's coming from the anal canal to the skin through the fistula. To learn more about these diseases, watch my video titled Clinically Oriented Anatomy of the Pelvis and Perineum. Here is the rectum, and this is the anal canal. And this is the pectinate line. So we have anal canal above the pectinate line and anal canal below the pectinate line. Above the pectinate line is endoderm. Beneath the pectinate line is ectoderm. Why is the upper one endoderm? Because it's part of the gut. Why is the lower one ectoderm? Because it's part of the skin. And if you remember your embryology, the ectoderm gave us the epidermis of the skin. Above the pectinate line, we have these columns of Morgani, and they end up as valves like these. These are anal valves. Why should I care about the anal valves? Because if one of them ruptures, I get an anal fissure, which is an extremely and exquisitely painful condition. It's so painful that the patient will never let you examine it.
What should I do then? Take the patient to the operating room to repair it?
How can you repair something that you have not diagnosed first? First, you gotta diagnose it, so you gotta examine the patient.
But the patient will not let me.
You have to examine the patient under anesthesia before you can know what exactly is there in order to repair that thing. These are the mucosa of the rectum. They have rugae, just like the mucosa of the stomach. It has rugae. The wall of the rectum or anal canal is made of 4 layers, just like the wall of the colon, small intestines, stomach, and esophagus. From the inside out, we have mucosa, submucosa, musculosa, serosa. We call it serosa when it's covered by peritoneum. We call it adventitia when it's not. The internal anal sphincter is involuntary, but the external sphincter is voluntary. The internal involuntary supplied by autonomic, visceral, nerve fibers, sympathetic and parasympathetic. Sympathetic from the sympathetic plexus, parasympathetic from the pelvic nerves, S2, 3, and 4. As for the external sphincter, it is supplied by somatic nerve fibers, which come from the inferior rectal nerve fibers, which came from the pudendal nerve, which is somatic. Above the pectinate line, endoderm. Below the pectinate line, ectoderm. Because you remember, your gut came from the endoderm, but your skin is derived from the ectoderm. Above the pectinate line, insensitive to pain. Below the pectinate line, sensitive to pain. Internal hemorrhoids bleed, but external hemorrhoids hurt. Why don't the internal ones hurt? Because they are internal. And internal is autonomic, which means insensitive to pain. If you remember your neurophysiology, pain is a somatic sensation. Above the pectinate line, I'm still part of the hindgut, which means I'm going to be supplied by a branch of the inferior mesenteric artery, and I'll be drained by tributaries of the inferior mesenteric vein. But below the pectinate line, I am supplied by arteries of the pelvis and perineum. I'm drained by different veins. Above the pectinate line, drain to inferior mesenteric lymph nodes, but below the pectinate line to superficial inguinal lymph nodes, just like the external skin. See, medicine makes so much sense once you understand what the French toast you're talking about. Here is the rectum and anal canal. There is the internal anal sphincter, involuntary, and external anal sphincter, voluntary. And this is the most important slide in the entire stinking lecture. Here's the anal canal above the pectinate line and below the pectinate line. Above the pectinate line, I'm supplied by the superior rectal artery and middle rectal artery. The superior rectal artery came from the inferior mesenteric artery because that's the artery of the hindgut. But below the pectinate line, I'm supplied by inferior rectal artery, which is not part of the inferior mesenteric artery. Where does the inferior rectal artery came from? From which artery? Please comment below. You'll find the answer in the next video. Venous drainage of the anal canal above the pectinate line, superior rectal vein and middle rectal vein. How about below the pectinate line, inferior rectal vein? Above the pectinate line, mostly portal circulation, but below the pectinate line, caval or systemic circulation. This guy is going to the portal vein, but this guy is going straight to the inferior vena cava. And that's why if I have cirrhosis of the liver, I can have collaterals opening up. And these are called portocaval or portosystemic anastomoses. One of the sites of the portosystemic anastomoses is around the anal canal. It's called hemorrhoids or anal varices.
Can you get anal varices from cirrhosis?
Yup. You can also get esophageal varices from cirrhosis, and you can get caput medosae from cirrhosis. These are sites of portocaval anastomoses. Portal is referring to the portal vein. Caval is referring to the inferior vena cava. Lymphatic drainage. Above the pectinate line, I'm going to the internal iliac lymph nodes. Below the pectinate line, I'm going to superficial inguinal lymph nodes. Innervation. Above the pectinate line, it's autonomic, it's visceral, it's splanchnic. Insensitive to pain, but sensitive to distension. Distal to the pectinate line, inferior rectal nerve, which is a branch of the pudendal nerve. These nerves are somatic and they are sensitive to pain indeed. During per-rectal examination of a patient, passing the gloved finger through this part is gonna hurt, but above here, it's not gonna hurt. The patient will not feel any pain, but the patient might feel distension. Why do we divide the anal canal like this, above the pectinate line and below the linea pectinatum? Because of embryological difference. Above the pectinate line is derived from the endoderm because it's part of the gut, but below the pectinate line is derived from the ectoderm because it's part of the external skin. Next, bladder and urethra. You have 2 kidneys, 2 ureters, 1 bladder, 1 urethra. The kidneys and the ureters are mesodermal in origin, but the bladder and urethra are endodermal in origin. But let me tell you something, the trigone of the bladder, which is very smooth indeed, is part of the ureter actually. So it's part of the mesoderm, not endoderm. If you want to learn more about endoderm, mesoderm, ectoderm, if you want to learn about the urogenital sinus, check out my embryology playlist. Here are the 2 kidneys, abdominal aorta on the left, inferior vena cava on the right. Don't forget that the left renal vein is long. And because it's long, it's going to receive the left testicular or ovarian vein. But the right testicular or ovarian vein is going to drain straight to the inferior vena cava. And this is of utmost importance when it comes to cancers, such as renal cell carcinoma on the right side versus the left side. And this is also important for superior mesenteric artery syndrome, also known as nutcracker syndrome. It's the disease that cracked my left nut, but not the right nut. Please refer to my video titled Superior Mesenteric Artery Syndrome. Look at these 2 ureters. In the beginning, they are anterior to the psoas major, then they become more medial to the psoas major until they hit the bladder from behind. What are these 2 lovely arteries? Oh, these are gonadal arteries on the right and the left. In females, it's the right ovarian versus left ovarian. In males, it's called right testicular versus left testicular. And here is the ureter behind the ovarian vessels. It's water under the bridge. The 2 ureters are going to end up in the bladder. This is the urinary bladder with the urethra underneath. This is the female uterus with the vagina underneath. And this is the rectum with the anal canal underneath. These are able to exit your body through openings in the pelvic diaphragm. Here is the bladder in males. How do I know that this is a male? Because I see the prostate gland and the seminal vesicles and the ductus deferens. This is the ureter as it relates to the ductus deferens and the seminal vesicle. This ductus deferens or vas deferens came from the testis, and then from the testis it ascends up and up and up until the ductus deferens join forces with the duct of the seminal vesicle, and these two ducts, ductus deferens and seminal vesicles, will join forces to make one common ejaculatory duct. Ejaculatory duct on the left and the right are going to open into the urethra. Also, the prostate gland is gonna help by secreting some doozy chemicals also into the urethra. Any part that is dilated like this is called an ampulla. So this is the ampulla or the ampulla of the ductus deferens. Most of the secretions of the seminal vesicles and the prostate are alkaline in nature because we are preparing the sperm to counteract the acidity of the vaginal canal. Otherwise, the sperm would leave the chat and humanity would go extinct. Now, do you think this is the anterior aspect of the bladder or the posterior aspect? This is the posterior aspect because the ureters hit the bladder from behind. Let's open the bladder up. If we open the bladder up, as you see here, all of it is corrugated except a triangle that's very smooth. That's the trigone, which actually belongs to the ureter, and that's why it's mesodermal in origin, but the rest of the bladder is endodermal. This is the ureter reaching the bladder from behind. This is the orifice of the ureter inside the bladder. At the neck of the bladder, we have the urethra. The male urethra is longer than the female urethra. The male urethra is made of several parts. This is the prostatic urethra, this is the membranous portion of the urethra, and this is the penile portion of the urethra. Other textbooks will divide the urethra into 4 segments, starting with pre-prostatic urethra, then prostatic, then membranous, then penile. This is the position of the flaccid male member, but the actual anatomical position of the male organ is an erect male organ. What if you're trying to insert a catheter? You will insert a catheter when the male organ is in this position, raised up and close to the anterior abdominal wall. If you have inserted a urinary catheter to a male patient before, you would have noticed that the catheter is hardest to pass in the intramembranous part, the membranous portion of the urethra. After you pass the membranous portion of the urethra, it's gonna flow smoothly until it ends up in the bladder. Why is it difficult to pass the catheter through the membranous portion of the urethra? Because it's surrounded by the sphincter urethrae muscle, which is the external urethral sphincter. The urethral sphincter. And just like the anal canal, the urethra has an internal sphincter and external sphincter. Internal sphincter, involuntary. External sphincter, voluntary. Which means that the internal involuntary urethral sphincter is supplied by autonomic fibers, sympathetic and parasympathetic, but the external urethral sphincter is supplied by somatic nerve fibers. When the seminal vesicles and vas deferens join forces to give me the common ejaculatory duct, where does the common ejaculatory duct open? It opens in the prostatic portion of the urethra. Here is the ureter hitting the bladder from behind. There is also the vas deferens and the seminal vesicles. After the bladder, you have the urethra. This is the prostatic portion of the urethra, membranous portion of the urethra. By the way, why do we call it membranous portion? Why membranous? Because of the perineal membrane. Remember that the perineal membrane is mostly in the urogenital triangle, anterior, not here, but here. Then there is the penile portion of the urethra. This is the external urethral orifice. The tip of the penis is the glans penis. The glans penis is covered by the prepuce, commonly known as the foreskin. For the innocent medical students who were homeschooled, foreskin does not refer to the skin of your forehead. Here is the ureter behind the bladder. There is the vas deferens coming from the testis. Seminal vesicle. The vas deferens is going to join forces with the seminal vesicles to give us the common ejaculatory duct, which opens into the urethra. This is the prostate gland. Behind the bladder and the urethra, we have the rectum and anal canal. In females, here is the rectum and anal canal, uterus and vaginal canal, bladder and urethra. The female urethra is shorter. This is the meatus, or the opening of the female urethra, which is anterior to the vaginal opening. If a female is complaining of stool coming out of the vaginal canal, that's a fistula between the rectum or anal canal and the vaginal canal. You can call this rectovaginal fistula. If a female is complaining of urine coming out of the vaginal canal, this could be a fistula between the bladder and the vaginal canal, vesico-vaginal fistula, or between the urethra and the vaginal canal, urethrovaginal. The former patient will complain of soiling the underwear with feces, but the latter patient will complain that the underwear is always wet with urine. Another patient that might complain of underwear that is always wet with urine is a patient born with a congenital anomaly known as low implantation of ureter. Normally, the ureter should be implanted here in the bladder, but in some patients it gets implanted here in the urethra. We will talk about more diseases in my video called Clinically Oriented Anatomy of the Pelvis, which you can find in my anatomy playlist. Here is the male urethra. This is the pre-prostatic portion. This is the prostatic portion. Oh, and by the way, the common ejaculatory ducts are gonna open here in the prostatic portion of the urethra. Then there is the membranous part of the urethra, surrounded by the perineal membrane and related to the external urethral sphincter. Where's the internal urethral sphincter then? Up here. Internal sphincter is up here, external urethral sphincter is down here. After this is the penile portion of the urethra. Don't forget that the male urethra occupies the corpus spongiosus of the male organ. The corpus spongiosus of the male organ is continuous with the bulb of the penis. Do you remember the bulbospongiosus muscle, the BS muscle? Whereas the corpora cavernosa of the male organ are continuous with the crura of the male organ. There are 3 organs in anatomy that have crura. Each one of these organs has a right crus and a left crus. These 3 organs are 1. The diaphragm, 2. The clitoris in females, 3. The penis in males.
What diaphragm are we talking? The pelvic diaphragm?
No, the diaphragm between your thorax and your abdomen. Did you know that the name Andrew literally means male? That's why andrology is the study of maleness. And in the next video, we'll talk about andrology and gynecology. We shall talk about the prostate, scrotum, testes, epididymis, vas deferens, the male organ, the ovaries, fallopian tubes, uterus, cervix, vagina, vulva, all kinds of uterine folds, uterine membranes and ligaments and pouches. We'll talk about the branches of the internal iliac artery in detail. We'll talk about lymphatic drainage of the pelvis and perineum as well as innervation. And in the video after that, it's clinically oriented anatomy of the pelvis and perineum, my best part. Before I leave you, please take a moment to review these 2 triangles, as well as the anal canal above the pectinate line versus below the pectinate line. And here is a question for you. You see these ovarian vessels? They pass inside a ligament. What's the name of that ligament? Please let me know your answer down below in the comments. And please tell me, if I have oral cancer, where will that metastasize? How about lung cancer? Which lymph node? How about laryngeal cancers? Where do they metastasize? How about ureteral cancer, vulvar cancer, anal cancer, rectal cancer, colon cancer, breast cancer, and scrotal cancer? You'll find the answer to all of these questions in my previous video on the abdomen, which was titled Anatomy of the Abdomen Ultimate Review, which is video number 2 in our discussion of anatomy. Do you want to learn about the physiological changes of pregnancy? How about the pathologies of pregnancy? How about labor and delivery, the different stages of labor, normal and abnormal? How about heart disease during pregnancy, kidney disease, liver disease? You can learn about all of these subjects by downloading my obstetrics and gynecology high-yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about all of the drama that takes place in your kidney's proximal tubule, loop of Henle, distal tubule, collecting ducts, and more, download my kidney physiology course on my website. To learn about estrogen, progesterone, androgens, insulin, glucagon, and more, download my endocrine pharmacology course. To learn about diuretics, antiarrhythmics, anti-anginal drugs, antihypertensives, antihyperlipidemics, and digoxin, download my cardiac pharmacology course. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, and physics make perfect sense.